Open the floor for discussion.
Hello, thank you for the wonderful presentations, both of them. I would just like to have a comment on the first one. My country, Slovenia, strongly agrees with opiate substitution treatment, with many drug users being on it. However, we should not forget on occasional relapses in this population, because in my country, between 20 to 60% of them are occasional drug users, in this case, meaning like being recreational drug users if they are steadily on opiate substitution treatment, and that gives rise to possibility of bloodborne viruses transmission. So keep in mind that patients on opiate substitution treatments should get additional information and constant counseling on prevention of infection. Thank you.
Microphone 4, Jonathan.
Thank you for two wonderful talks. Both of them were really very comprehensive, and I appreciate both of them. I think they highlight the issue of drug interactions with drugs, with nutrients, with herbal medications, which can also change from country to country. I think perhaps in HIV care, we focus very much on activity and resistance, and we a little bit neglected the importance of pharmacology. And I think that one criteria for us for better drugs, I think as Anka mentioned, is for them to have simply less potential. Because it's so difficult to consider all the interactions. I think for us, a real benefit of drugs, and when we look at different regimens, both for HIV and for hepatitis C, and even maybe when countries are deciding on policy, I think drug-drug interactions is a very important characteristic. And in addition to looking at, potency and resistance, drugs that have less potential for drug-drug interactions are going to be more favorable, especially if we want to give them widespread. I think you both highlighted that very nicely.
Yeah, so I have a question. First of all, thank you very much for the nice presentations. You showed that there's a high potential for interactions between HIV protease inhibitors and HCV protease inhibitors. You cited the ASLD guidelines, which do not recommend the use of the AbbVie regimen with boosted darunavir. However, there have been trials looking at that particular combination, and in the EX and European guidelines, there's not the same level of contraindication for using that. Can you clarify that?
As I mentioned, my talk was from the point of view of the clinician, so I put the guidelines just as a guideline. I do believe we'll need some further studies on that, and we'll need the input of the pharmacologist in order to look better at that point of view. So for the meantime, safer is more secure, so to say, and this is why I highlighted that point. But please comment on that. That is in your field as well.
Because I think it's relevant in the because I think what Jonathan said is, well, if we use drugs with no drug interaction potential, that's obviously the safest way forward. But we also have to appreciate that in certain countries, the prices for integrase inhibitors, which are sort of an obvious choice, are much higher. And unfortunately, the pricing strategy of the companies there has been very rigid. And so, as a consequence, other drugs are being used. And I think in that scenario, there are countries, and if you look at your own country, where you presented 59% being on a PI for HIV treatment is a very common regimen. So the question is how to deal with that if you cannot switch to an integrase inhibitor. And at least in the German context, a lot of people have been treated with darunavir because there is a decrease in the levels, but since levels on average are high, and there's a difference between patients who have resistance for HIV and may require higher drug levels, and that's where I think I would be worried. But in a treatment-naive patient or a patient who has not accumulated resistance under any regimen, I would feel safe to use the combination with darunavir and the AbbVie regimen. And that has also been used in various trials and gives support from that standpoint. And I think it's important. So I do disagree with the ASLD guidelines in that respect. So, if I move, I lose count.
Good for you. Jürgen, you raised a very interesting subject linked to darunavir, boosted darunavir. But at the same time, I think that we have to look to the site of the link of the protease inhibitor and the duration of the link. So I don't think that this kind of coordination drug-drug interaction are direct connection to the life, because if we are looking what our patients do home, it became crazy. You say, don't drink, I don't know what tea. They drink this tea, nothing happened. But in pharmacology, it's prohibitive. Yeah? Don't take omeprazole. They take omeprazole. In the literature, it's forbidden. So I think that we have to pay attention to how important we put in our mind as physicians this kind of drug interaction. It's a fantastic subject. Probably in the coming years, we have to sit with our smartphone and say, okay, smart monitor is listed, and then to take a decision, but the patient, it's only one.
So, just one comment on, one comment on the important discussion between all the colleagues here. And indeed, as Jürgen said, there's debates on this. And actually, at the Liverpool website, we debated this a lot. As Jürgen said, it's actually a three-way interaction, of course. You have the darunavir, you have the ritonavir, and you have the hepatitis C protease inhibitor. Three drugs. They both interact at the level of the CYP3A4, but they also have transporters like PGP, which interact. So with three drugs, with transporters, and with metabolism, all interacting. And obviously, you're not going to have a clear-cut decision. And it really comes to how much danger or how much caution you're willing to exert. And I think Jürgen makes a good point. It's a continuum. And I think the Americans here were more conservative and said even a small chance we're not willing to accept. Whereas in some European forums, the feeling was it's a very small risk and we're willing to accept it. And I would just make the comment that on the Liverpool website, as Anka was showing, there's sort of three levels. There's the green, which is good. There's the amber, which is be careful, you can maybe use it. And there's the red. But it's a continuum. And I think, you should really stress that the amber can be something which is pretty safe or not so safe. So it doesn't completely release us. I think we have to consider, for example, for that interaction, if you don't have money for anything else, that's relatively a small risk to accept. And it probably, as Jürgen said, it depends on the patient. On the other hand, if you're in a country where you have all options, I think, you would prefer not to. I think, again, it raises the issue that it's not an all or none. And that all the colors that we use on the Liverpool website need to be considered, even if you look at, for example, red interactions. And just to give an example, sofosbuvir and amiodarone. We're all terrified of it. And because there were case reports, we're terrified to use it. But actually, in some cases, we have to use it. And we monitor the patient's EKG. And many patients, it's fine. So again, I think we have to keep our clinical judgment, and I think that highlights an important issue.
Exactly, discussing that there are patients and not, we cannot apply to all the patients. The thing is that initially, when darunavir was put up on the market, after the studies, they said there are no interaction with methadone. Putting in the real life, it was shown that there is a diminishing in the level of methadone about 10%. But that's in 90% of our patients on methadone has no clinical relevance. So because they are a long term on the methadone, already they need a reduction in the dose, or they are afraid to do this. So the reduction induced by darunavir is not really clinically relevant. So it's the Liverpool scale, it's updated every 6 or 9 months. So we should look in there, but not forgetting that we have to treat patients and to take each individual. Thank you.
My worry remains with the drug-drug interactions, with multiple interactions, when the amber becomes red and there is multiple things. But I think this such a tool, which would be like, I think, neural network for multiple interactions is yet to be invented, from my understanding. Yeah. Okay.
And maybe I just would like to make like final comment from myself. We are talking about drug-drug interactions now, but the same, I think we should talk about intersectoral cooperation interaction and very concrete, for concrete patient, very concrete case management, intersectoral case management. Otherwise, drugs are coming and coming. We have better and better tools, but as Anka mentioned, we need to treat concrete patient. So let's close.
I think we are up to the coffee and croissant, so the coffee break. Thank you very much for the session.